One of the questions is order of therapy and how we would choose different treatment options. And so I just wanted to briefly hear from you how you would put these in. Assume that tucatinib and margetuximab are approved, and we've given pertuzumab in the adjuvant or neoadjuvant setting, or somebody's in the de novo metastatic setting and they've gotten both pertuzumab and TDM1. Of course, there are patients who will have received both pertuzumab and TDM1 in the adjuvant setting now, who will get it in the metastatic setting. So how would you choose what agent you use in what sequence? So, and then we'll hear how the payers actually look at that. So you want to briefly comment on that? How would you choose which agent at which setting?
Yeah, I think, from Claudine's presentation and what I've been thinking about quite a bit is looking at the tucatinib data. I mean, obviously we'll need to see what that label looks like and what line we'd be looking at, but the fact that that benefit is there and it's an overall survival benefit, not limited to patients with brain metastases, but really anybody with that prior exposure, HER2 positive disease, at least third line. I lean towards the tucatinib, although remembering that's in combination with capecitabine, in combination with traz. Despite the fact that the DS8201 traz deruxtecan had such a beautiful waterfall plot, it is really a single arm, non-randomized presentation. I think there's great activity there, but that is balanced with the ILD concerns. So with the available drugs before me, recognizing many of these women will have seen pertuzumab and likely TDM1, I lean a bit towards that overall survival advantage from tucatinib. And it would be wonderful to see a time when perhaps tucatinib is able to minimize the development of brain metastases, even more so than being able to treat it once they're present.
Yeah, that's a really good point. And I think that it was very clever of them to add trastuzumab to the combination, which I think my guess is really made a difference in their ability to see big differences in overall survival with an antibody component, Priyanka, how about you? How would you use these in what order?
So, assuming that we're making a choice in third line setting and we have all the drugs available, another factor that would come into play would be the oral versus intravenous, multiple drugs versus single agent. And previous risks or with interstitial lung disease with other drugs in the past, that would play into the decision-making, presence of brain metastasis, even if they're controlled. But having a phase 3 trial that shows a survival advantage obviously makes a difference in that choice. The other factor is the Destiny trial included patients that were pretty heavily pretreated. So I would feel comfortable using the tucatinib combination in third line setting and saved trastuzumab deruxtecan for later lines of therapy, since the trial population included heavily pretreated patients.
Claudine, do you feel the same way?
I do. I feel exactly the same as my my esteemed colleagues here. And I guess the only thing that I would add, now that I'm the third and I have to think of something to add, is occasionally I think we have those patients who just for reasons that we don't understand have blown through all of these other things very rapidly. And I think one of the things that really impressed me with the Destiny trial was the responses that we're seeing in patients who'd had a lot of prior treatments and the rapid response. So I think in those patients where we feel we need to slam the brakes on and we don't have much time, that might be a patient population where I might move this drug up. But otherwise, I think of, based on the phase 3 data, the survival, the benefit with brain mets or not, I would use tucatinib as my third line drug for the vast majority of patients.
Yeah, and there are always those patients who don't tolerate capecitabine for a variety of genomic reasons. But John, these, now we're coming back to the same area again about, the oral therapy versus IV and share of cost and how we decide, if there are a lot of different treatment options available, where does the insurer fall in terms of trying to help us and also decide what's going to be reimbursed?
Yeah. Well, first of all, I'd say, especially in these late line therapies, the number of patients that are going to receive these therapies is relatively small in comparison to first line therapies. Certainly, we'd prefer regimens that are replacement therapies versus add-on therapies. So instead of a 3-drug versus 2-drug, a 2-drug versus 2-drug. I was particularly interested in the HER2 climb study with tucatinib This is very reminiscent in the non-small cell lung cancer space, where osimertinib, which is a second or third generation TKI for patients who had EGFR mutations, not only treated brain mets, but also reduced the likelihood of development of brain mets, and was subsequently approved as first-line therapy. And we'll see if tucatinib makes that same progression from third line to earlier line therapies. Interestingly, and just by way of analogy, in our OCM practices, when providers are presented with that data and shown the prices of osimertinib versus erlotinib, they said, you know, this drug is so much better that we're going to use this, even though it's more costly. But another example in a ROS1 mutation in non-small cell lung cancer, when comparing crizotinib and ceritinib, they said, you know, there's a cost difference, but we don't think there's a justifiable an outcome difference, so we're going to use the lower cost therapy. So that's how providers are reacting to some of this data. But I think, again, to go back to your question, I think payers are going to, as long as it's being used in consistent with the FDA label, the NCCN guidelines, there's going to be access to these therapies, especially given the fact that most of these drugs, because they're new, don't have long-standing data. So we're going to defer to the oncologists in deciding which ones to use.
Of course, that's very, you know, music to our ears in many ways. But
yeah, I mean, frankly, we can't even pronounce the names of most of these drugs, let alone decide where to use them. So I think we're going to defer to the NCCN guidelines. And unlike most guidelines, the NCCN guidelines are kept very up to date.
We practice names all the time. So this has been a really interesting discussion. I think highlighted some of the tremendous advances that we've seen in HER2 positive disease. And of course, we're all very interested to see how this moves into the early stage setting and how some of the very active drugs move earlier in the course of therapy to try and, you know, sort of reproduce what we saw when we first started using trastuzumab, where we were curing patients with incurable disease. So I think that still remains an expansion area. And of course, trastuzumab deruxtecan is being tested in patients who have a previously undefined subset of disease, HER2 low, 1+ and 2+ by immunohistochemistry, mainly ER positive, but a small subset of triple negative disease in an ongoing randomized phase 3 trial. So that's going to also provide us with a lot of interesting data in another group of patients altogether for the first time.